Hello everyone, this is Chadi Alraies from NCVH 2024, and this is the 25th anniversary. I'm really privileged to be with Dr. Frank Tursi to talk about the track of podiatry and involvement in NCVH. Dr. Frank, thanks for being with us.
Thank you very much for having me here. The podiatry track and wound care track was recognized by Dr. Walker almost 20 years ago now. And in meeting Dr. Walker, he recognized in my profession a vehicle with which we could get more patients into the cardiovascular pipeline. As a podiatrist, we're typically referred to as the first responders to recognize peripheral arterial disease.
Right.
So we look at legs and feet all day long, and when we do, if there's certain cardinal signs that would suggest that the patient themselves has peripheral arterial disease or venous disease, we then go ahead and recognize it, vascular testing, and then get it in and refer it to one of our cardiovascular colleagues.
So what is one of the red flag for you to say this is a vascular disease, PAD-induced ulcer versus, you know what, I don't think it's PAD, it's diabetic foot ulcer or venous?
So when you look at a lower extremity, the first thing you look at is the color of it. If it's blanched and looks kind of whitish, more pale, that's suggestive that it's not getting perfused properly. If it looks dark and maybe a bluish, and maybe the vein or venous system is not returning the blood flow correctly, you then feel for temperature. If there's increased distal cooling, meaning as you go from the shin down to the toes, and it gets really cold at a certain level, that's a good sign that the blood flow is not going through as far as it could be. Also, you may see signs of ulcers. Ulcers are sores that typically won't heal if there's a vascular condition. If the ulcers are small and sort of well demarcated, so they look like somebody took an ice cream scoop and scooped it out, they're very sharp edged, that tends to be more of an ischemic ulcer or a lack of blood flow. If they're larger and more shallow and draining a lot, that's more suggestive of a venous disease.
Now, you make a diagnosis, you refer to a cardiologist or cardiovascular specialist. Besides revascularization, what kind of medical therapy that will increase patency for this revascularization to improve healing?
Well, and that's when I send patients for cardiovascular assessment, and I find that they have a wound or they have other cardinal signs that suggest peripheral arterial disease. Frequently I send them to the cardiologist in my area or an interventional specialist, and they'll do a full workup, and they'll come back to me or tell the patient, you know, Dr. Tursi saved your life. Because not only do you have perfusion problems in your legs, you have it in your chest or you have it in your neck. Recognizing again the earliest place that PAD develops, being the lower extremities, you then can get that patient into the lifeline, the cardiovascular lifeline. Absolutely. And those patients can be assessed fully, and if there is something that maybe is going to make them prone to a stroke or a heart attack, they can be addressed properly. After that, then there's smoking cessation programs, so maybe patients themselves smoke. That's a big contributing factor to this. Exercise is another great thing. It's sort of a catch-22 because a lot of times people with vascular perfusion issues have pain when they try to exercise. So we try to get them where the blood's flowing better and then get them up and actually work to reverse some of that problem that they have circulation.
Final question is, and from your experience, again, this is something random, I don't think there's a study. Have you seen more patients coming to you because they have cardiovascular disease, came to you with foot ulcer, or the other way around? Have a foot ulcer and they ended up with more cardiovascular disease?
Most of the time it's the opposite. It's the ulcer first, because again, we're there and we're there to see them for their foot and their leg, and a lot of times they don't know why this happened. I can't tell you how many times I've been in a rehab facility or a nursing facility, and I'll talk to a patient and I'll talk to the nursing staff caring for her, and I'll say, you know, we need to check this patient's circulation. And they'll literally come to that aha moment where they'll go, maybe that's why Mrs. Jones' ulcer hasn't healed, because she's got circulation problem. Well, how long did it last? How long has the wound been evident? A year.
Open a can of worms of multiple things. Thank you so much, Frank, for all your hard work and for being a big advocate for podiatrist education, as well as for teaching how to assess patients with wound care as well. Watch these videos and others on NCVH 2024. This is Chadi Alraies from New Orleans. Frank, thanks so much.
Thank you very much.
Thank you.
Appreciate it.
Thank you.